are you?
Morning.
Good. All right. Let's see. Okay. I guess we should get going. It's a relatively abbreviated one today, so let's go. Okay. All right, where are the leads? This is a patient who's had a lot of pacemaker surgery. So why don't we go to Dr. Barris? Where are the leads?
Okay, so number one looks like maybe an epicardial pacemaker lead.
Mm-hmm.
Number two is, I guess, would also be epicardial. I'm trying to figure out exactly where the wire course is, but I would say it's epicardial.
What do you think, if I might interject, what do you think's going on here with number one? So it is epicardial, but is it unusual to you the way the lead appears?
I mean, I only see a small portion of the wire.
Right.
So that's kind of odd.
Okay. All right.
Number,
What do you make of
sorry?
the fact that this lead is this lead on the heart?
It looks like it's off the heart.
Yeah, it does, doesn't it? Okay.
And number three, I would say, is a in the RV.
Mm-hmm. Whereabouts do you think?
Inferior portion.
Yeah, sort of towards the apex. Uh-huh.
And then number
What do you make of the, does it seem to be attached to the pacemaker?
It does. I mean, I don't see the wires contiguous with the transvenous wire.
Mm-hmm.
And number four, it looks more, innominate to SVC to coronary sinus.
To coronary sinus, okay. It's possible it could do that, but this is not actually what a coronary sinus lead looks like. They're usually much thinner. This is just in the RV outflow.
Okay.
Okay. It'd be hard to tell in single plane. But I show this image because I think it's an interesting one in that it shows what happens to patients who have pacemakers and problems you can incur and why getting heart block after surgery is not a nothing thing. This is at the time of this x-ray, I believe the boy was something like 18 years old, and he had a VSD repair, was left with postoperative complete heart block, and initially got this lead, which is when you see this type of lead, these are the Medtronic steroid-eluting epicardial leads. This is a unipolar lead. And the fact is it ends blindly here because it has broken. And years ago, when somebody did a generator change or whatever, they took out the device that was in the abdomen. And when they took it out, it probably snapped. Or rather the piece that was going from the lead back to the pocket was removed. As a result, the surgeon then tried to put this pacemaker wire in. This is a so-called screw-in electrode, aptly named because it has a screw there. And this was an old technology that was used very commonly in the past as an epicardial lead. And what would happen with these leads is that they would have an excellent threshold with a very large R wave when they were first put in. But then within 6 to 8 weeks, they would often develop what we call exit block, or essentially a very high threshold. And so they ended up falling out of favor because they were very unreliable, even in medium term as pacing leads. In this particular case, you could see that it actually came free from the heart, which is a little strange looking, but this obviously happened many years after it was put in, although one has to wonder what's on this wire if it came out of the heart after it was screwed in. This lead was placed. So after both of these leads failed, when the child was by this point about 5 years of age, this lead was placed and transvenously by me with a heart surgeon many years ago. And at the time that this lead was going in, we attempted to extract this lead and we were unsuccessful. And so you see a very large piece of retained lead, as well as, if you look very carefully, there's a fine filamentous portion that's sort of going back in. This was about 8 or 9 hours of effort to try and extract this lead unsuccessfully. And so then we placed this lead next to it. So, and I might add, the saga never ended here, because the patient ended up, eventually this lead failed, and we had to place an entire new system from the right side because the family refused another extraction attempt because of how long and difficult and unsuccessful this extraction was of this lead. So putting in pacemakers and stuff is not a benign thing for some patients. Also, this patient ultimately developed pacemaker-induced cardiomyopathy as well. So it's not a nothing thing to need a pacemaker as a baby.
Dr. Pass,
Yes.
so given, all the complexities and complications of trying to extract a lead, aside, space, if we need to put a second lead, why do we, I guess I'm trying to weigh the pros and cons of lead extraction.
Excuse me. That is an excellent question, Uzo. So first of all, I'll be completely honest in saying that at the time that I put this lead in, I was working at Montefiore and I was by myself. I didn't yet have a second electrophysiologist, and I had, relatively small experience in implanting leads. And so I appropriately asked for help and asked for the head of adult pacing at Montefiore at the time was and is a guru of pacemakers and extractions. And he said to me, excuse me, that he would only help me if I would allow him to extract this lead. And his rationale for it was that we know that the longer leads are in, the more difficult they are to take out. We also know that pediatric transvenous leads tend to be amongst the most difficult leads to extract because children have a very exuberant scarification. And so even if you just sort of take 2 leads in 2 different patients of the same length of time, if the patient is, like, say, less than 10 years of age, the chances are very high that extraction of the lead is going to be greater. The risk of extraction is not that it took 9 hours, although that was unpleasant and whatever. The risk is that you're going to tear something. Either you're going to tear part of the tricuspid valve, which may be attached to the lead, or more scary is that, and more common, is that you'll tear the superior vena cava or the innominate vein in the process of trying to pull it out. And if that happens, you could have an uncontrolled bleed, and you could even potentially be fatal. Now, there are a number of techniques to reduce the risk of that happening. And I think if you look at most of the literature, the risk of that is about 1%, but that isn't negligible. And so in truth, my general approach has been to leave leads in. Now, my adult colleagues are very angry about that because they're going to be left with some serious problems with vascular access and everything else. But I would argue that if the lead is good, that's one of the reasons you wait until a patient is older in a perfect world to put in transvenous leads, because in a perfect world, you'd rather than extract, just want to put another lead next to the lead. Now, this is a philosophical difference. There are lots of pediatric electrophysiologists who think that every lead that goes in should come out, particularly when you're putting a new one in. And I certainly understand that rationale, and most of the time that's fine. But on the other hand, it is not a zero risk endeavor. And if you do enough of these, eventually somebody who's basically healthy is going to have a serious event when you do extraction. So my general approach, quite frankly, has been to put my head in the sand and to just put leads next to the old leads, because of concerns associated with extractions. It's not a zero risk thing. The other reason that some would say it would be useful to take these out is that if a patient later in life were to develop sepsis or a serious infection, these leads could become a nidus for infection. And then you would have a very serious, very difficult problem. And it turns out that this lead that we could not extract is a Boston Scientific old-fashioned lead called a sweet tip lead. Many of you have seen that when Barry and I put a pacemaker lead in, the lead has a screw that screws out and into the lead itself. Once the lead is in good position, you literally twist the end of the lead and a little screw starts protruding out of the end. This lead number 3, the one that we could not extract, is a so-called sweet tip lead. It's an older technology. So the reason we used this lead was that it was only 5 French. Most pacing leads are 6 or 7 French. And in a 5-year-old, because we were already unhappy that we had to put a transvenous system in, but we had no choice because we had now had 2 failed epicardial systems. In this particular case, we put the sweet tip lead in because it was very thin. It was only 5 French. In fact, the other name for this lead is the thin line lead. It's still sold. It's an excellent lead. It's actually surprisingly robust and strong. And the reason it's called a sweet tip is it's very interesting old-fashioned technology. So the screw is actually exposed in this lead. As you would imagine, if you're pushing the lead with an exposed screw through the vein, with venous valves and such, you could get into some trouble. You might even perforate. So what they very smartly did was they coated the screw with a sucrose solution that causes it to be rounded and not sharp-edged. And once it's in the bloodstream for about 1 to 2 minutes, that will dissolve, and then you have an exposed screw, presumably by the time it's in the body, in the heart. And so when you're in good position, you would literally screw the entire lead and it would screw this little exposed screw in, similar to a regular lead, except that the screw doesn't come back in. It always is exposed. So these leads worked extremely well. What I've come to realize since the time that we put a huge number of these in is that I'm not entirely sure why, but this is one of the most difficult leads to extract. In fact, it's a nightmare for most electrophysiologists who do extractions, and many of them will just not even try or expect that they're going to have a very hard and long day in the lab, and that was exactly what happened with this lead. So you're right to ask the question whether it was worth extracting. In retrospect, the answer would be no. It was not a good idea to extract. It was a good idea, but it was not necessarily the only idea. All right, normal or abnormal? I'm going to ask Dr. Ahluwalia.
Morning, Dr. Bass. So we have one AVFB1, and then we have a His catheter, and then we have a HV, and we have a AHV. So in this first one, the AH is very small, short, almost like it's not simultaneous, but almost simultaneous. And then the HV is super prolonged. I mean, I don't have the time, but it looks long. And similarly, on the surface EKG, you can see that the APR interval is super long. And the QRS is wide. And then the second beat that we see is just an A and an H, and we don't see a V. So it's like a drop. And then again, we see an A and an H, and then a long V. So this is, and then the third beat is again not conducted. So every other beat is the third. Yeah, we don't see the last one, but in this strip, every other beat is dropped, and the PR interval is prolonged. So it is second degree heart block. Yeah, second degree heart block, I think.
Well, is it supra-Hissian or infra-Hissian block?
Infra-Hissian,
It's infra-Hissian, right?
right?
Why is that? How do you know that?
Because your HV is long.
Well, and because you have an A and H and no V,
You know V, right?
right?
Sorry.
So this is an unusual circumstance where the AV node is okay. This AH interval is actually in the normal range. It's hard to tell, of course, because the scale is bizarre, but the AH interval is normal, in this beat, there's no V afterwards. Now, I accept that you're saying that this A is conducting with a very long PR to this beat. Is that what you were trying to suggest, Neha?
Possible, yeah.
Right. But if you actually look, this PR interval is smaller than this PR interval. So this is actually isosynchronous beating, I believe. And I think this is actually, well, you're right, it's second degree block, but it's very high grade. I'm not convinced that the beat is even conducting at all. I think this is just a ventricular escape rhythm with infra-Hissian block. This is the type of block that we see in patients who've have heart block following congenital heart surgery. It's infra-Hissian block. So this is distinctly abnormal, and this would warrant a pacemaker if it were long enough after surgery. Okay. So this is an example of someone having tachycardia, and I'm asking the question of what is the mechanism of this tachycardia? So I'm going to speak with Dr. Uzoma Obiaka. What does she think?
Okay, so
We are in tachycardia.
Okay, so looking at the surface EKG, I don't see clear P waves, but let me calm down. So if I trace down, this is my V and my A. So oh crap, sorry. I just clicked something that took me out, sorry. So looking at my V, my earliest, so when I follow the surface EKG down and I go down to my V, my earliest V seems to be in CS7, 8. Seems to be my earliest V. So I would say like this is an ORT with a left-sided pathway.
That's right. And how did you make that determination? I agree with you. Correct.
And looking at, I was looking at the so the distal. I looked at my LAS3, which was in my CS7, 8. So letting me know that this is likely going to be a left-sided pathway.
Well, it's really, you're looking at the A's, right, to tell you where the pathway is.
Pathway is
Not so much the V's, right? You're using the surface electrocardiogram in order to help you
find
distinguish
my
where the V's are
T is.
on the intracardiac, right? So you know that anything that's simultaneous with the QRS is probably a ventricular electrogram, ventricular in the Hiss. And then anything that follows that
is my A.
Right? And so first thing to look at is the high RA. That's usually the easiest. And we see obviously that there is an A following every QRS, right? And then we're looking in the Hiss, and it's kind of a bad Hiss. It's not very clear, but maybe the A is somewhere around here. But then when we look at the coronary sinus, we see that that probably what's interesting is that these A's are later than these, and probably this A is earlier than this. So it's sort of an eccentric pattern of retrograde conduction, where the CS is similar in timing to the Hiss. So I think what happened was that the doctor first mapped the right side, determined that everything was laid on the right side, and then did a transeptal and went to this area. And you can see here that at this point, as the doctor is mapping, this is the V and this is the A. This is on the mitral annulus. You see that where the doctor has a catheter, that the retrograde A is late relative to the earliest coronary sinus A's by quite a bit. So he's not in the right position. Okay. All right. This is a text message I received from a colleague at another institution last week. Hi, can I get your opinion on this newborn EKG, 12 hours old, 35 weeks, asymptomatic, fetal echo normal, except variable heart rates to 200. 2 prior ECGs about 6 hours earlier are identical with a wide complex, same heart rate. Is this VT with retrograde Ps, slow reentry SVT, something else? Would you give adenosine? Management suggestions? Thanks. This is the tracing. So why don't we ask Dr. Sergey Babia what he thinks about this?
Good morning. So we have a wide complex tachycardia with a rate of about 150, 160. See if we see any P waves. So I'm checking V1 and second lead. And I have a feeling that it might be retrograde.
So I'll remind you that there was a paper we wrote many years ago that I've referenced about which leads are best to look at. And it turned out that lead V1 followed by lead 3 were the best 2 leads. And I think you would agree with me that in lead 3, there does appear to be something after each QRS that is suspicious for a possible P wave. Okay, so remember this is a newborn.
Yeah.
So this is the story at 12-hour-old, 35-week asymptomatic fetal echo normal.
Yeah, so the QRS should be very narrow in a newborn. This looks wide for a newborn. So I would think that this is either ventricular tachycardia, or it could be could be some kind of supraventricular tachycardia with some intraventricular block.
Okay, so how common is it to have bundle branch block in a healthy newborn who does not have congenital heart disease?
Probably unlikely, rare.
Exceedingly so. So, and what is the rate of SVT typically in a baby, a newborn?
It's 250.
Usually even higher, closer to 300, right? ORT in a baby. And then what other arrhythmia is commonly seen in newborns that's tachycardic? We've talked about many times. Hello?
Yes, I'm still here. I'm trying to remember.
Well, what would, if the heart rate were closer to 200 beats per minute, what would you be thinking of potentially? We're thinking about atrial flutter, right? Atrial flutter is commonly seen in newborns, but not usually with a heart rate of 160. So this is actually VT. And, you know, as you said at the very start, Sergey, astutely, babies rarely have a wide QRS. I think one of the first comments you said was, this is a wide QRS for a newborn. And that's absolutely true. And what's a little confusing here is that the QRS axis is similar to a normal axis, right? It's about 60 degrees, although probably a little bit too leftward for a newborn. But this is actually an example of neonatal VT. And so now you've made this diagnosis. What would you do for this? How would you treat this?
Is the patient hemodynamically stable or unstable?
Yeah, I mean, according to this tracing, the patient had an EKG 6 hours earlier that was identical. So let me ask you a question. If you waited another 6 hours, do you think the patient would be hemodynamically stable?
And probably it's going to be unstable.
Probably not a good idea. So we have to come up with a solution, which is why my opinion was sought on this matter.
Yeah, we need to treat it. So either we can do it, I guess we have to defibrillate under sedation, maybe.
Well, I
Or
would
treat it-
cardiovert, but
Cardiovert.
yes, DC cardiovert. That was in fact my recommendation. Would you do this in a synchronized or an asynchronous manner?
This one we will do in a synchronized manner.
Absolutely, 100%. You would synchronize cardiovert this. Now the patient is, and correctly, and thank you for mentioning this, you would sedate the patient for this. This I have seen in neonatal units sometimes that they will do this procedure without sedation. And as we always say, no baby ever complains, except, you know, we know that this is very painful. So you must sedate this patient. Interestingly, apparently during sedation, the patient converted to sinus rhythm just prior to being shocked. But let's say, are there any other options that you could try other than cardioverting the patient?
You mean medication wise?
Yeah.
Yes, you definitely can try things. For example,
Any idea of some things you might want to try?
lidocaine.
Yeah, you could give a patient a dose of lidocaine. Maybe you'll get lucky and it will terminate. How much lidocaine would you give, Sergey, as a starting bolus?
1 milligram per kilogram.
That's exactly right. Yes, you'd give 1 per kilo, see if it worked. You could even give a second dose if you wanted to. Whoops. You could give a second dose if you wanted to, but yeah, you could do that. Any other agents you could try?
How about amiodarone is always an answer.
Yeah, you could give amiodarone. I would probably not give it. It's not wrong to give it, but I wouldn't give it because of the rare incidence of severe side effects in newborns. But it's certainly not a wrong choice. People would do that. That might work. Any other agents?
Yeah, we'll be guessing.
Okay, so you could give procainamide. That's a good all-purpose antiarrhythmic agent. That's probably what would be considered in some centers. And those would be probably the main choices you would use. You could use IV sotalol, which is now available, but which we really have not used here at Mount Sinai very much. But some places love it. I think it's great. So, but I think the bottom line is cardioversion. And what would you imagine? What would you do after you cardiovert? So you cardiovert and you're having some random PVCs. What would you do? Would you do any chronic therapy? Would you watch it? Would you? What would you think?
I think we would do chronic therapy
Yeah, I think
in
for
this case.
I agree. I think there's no right answer, but I think for somebody who had a sustained VT that required cardioversion or almost required cardioversion, we would at least initially treat it on the theory or the hope that it would get better on its own. So what would you want to try or as an oral agent for this?
Amiodarone.
Yeah, you could put the patient on amio. You're a big gun guy. That's fine. Amio would be fine. Advantage of amio is it's a once-a-day medicine. It's easy for the parents. Obviously, we're all familiar with the multiple potential side effects, including thyroid, liver, lung, but as well as photosensitivity, which is an issue in babies, but not really. Most of those are long-term effects, and usually we would be off the agent before we would get most of those effects or be at risk for those effects. Anything else you might be able to try?
Oral.
Yep.
Sotalol, maybe.
Yeah, you could put the patient on sotalol. That's not an unreasonable drug. And then, of course, you could even try something simple like a beta blocker for this. Might be effective. You know, as you know, when it comes to treating these, it's a little bit trial and error, and there isn't really a right answer.
Thank you.
Thank you. All right, so this is a text I received in the last week or two. This is a 7-week-old with a history of interrupted aortic arch, status post-repair, post-up day 3, has tachycardia up to the 180s, was sitting in it for 3 hours. He is afebrile, didn't respond to fluid bolus. Now rate has come down to the 160s. Patient has a history of SVT pre-op and post-op on digoxin. EKG at rate 175 from today, and prior EKG at 142 shows similar P-wave morphology to me, but a doctor asked me to run the EKGs by you, and that doctor was concerned about EAT at 1:30 in the morning. So I think I am going to ask Dr. Barris what he thinks about this tracing. Do you believe that this is a sinus rhythm, not sinus rhythm? Should the doctor be interested in waking up the kindly electrophysiologist at 1:30 in the morning to review this tracing?
So just taking a look at our P-wave axis, I see the P-waves clearly upright in AVF, and I see P-waves upright in 2. I see P's before every QRS. You know, our axis is abnormal, but this baby's had cardiac surgery. In terms of, you know, I guess you couldn't really rule EAT out by this, but I definitely wouldn't rule it in. I guess I'd want to see if the P-wave axis changed from the baseline ECG to what we're doing on this study. If I guess in terms of the 1:30 a.m. question, if that is a serious question, I guess if the baby's hemodynamics haven't changed at all, it might be something to continue to watch.
Yeah, I mean, I'm being facetious about the 1:30 part. I don't particularly think it needed to be asked at 1:30, but that's another story entirely, and that's not here. And I want you to understand very, very clearly, I do not mind being woken up for anything. So if you want to call me anytime. I don't care. But my point is really, I agree with you, David. I don't really see anything on this tracing that is particularly concerning for EAT. If you look carefully in lead 1, I think you could say that the P wave is upright. And as you said, it's upright in 2 and in F. The other thing is that the morphology of the P wave does not appear abnormal at all. Looks very, very normal. And then another good hint about EAT, which we've spoken about a number of times, is that often, not always, but oftentimes patients who are in EAT are in first-degree heart block. It just takes longer to go from the A to the V in EAT. Oftentimes, probably because you're not using these little fibers that are in the atrium, like Bachman's bundle and things like that. And so that's often a good extra help in figuring out if you're an EAT. And I think we would all agree that the PR interval is quite normal. And really, when you look at the P wave in all the different leads, there isn't any really odd looking P wave. And then finally, the heart rate of 175. And, you know, I think the bottom line is that, is that basically the rates all sound good. And as the person wrote to me, let me just pull this up. You know, the rate was varying all over the place. There was EKG earlier at 142. The heart rate was in the 180s. Yes, EAT can vary, but I think the bottom line is there isn't anything particularly worrisome about a 1-month-old with a heart rate in the 170s or 80s in terms of rhythm. Now, of course, we have to understand or feel comfortable that we understand why the heart rate is 180. Obviously, 175, 180 is a fast heart rate, even for a newborn. And so, you know, I'm often going to ask you a question like, is there a fever? Is the child well sedated? Did we recently wean the sedation? Questions of this nature are not unreasonable given, you know, what we're concerned about. But there really is nothing in this tracing that is particularly concerning for the diagnosis of ectopic atrial tachycardia. And that's basically what I said at that time. I was glad to see that I made a good decision even in the middle of the night. All right, and I think with that, we'll stop for today. Thanks, guys. I hope you found this useful, and I hope everybody has a great day. I'll see you in just a few minutes at sign out.
Thank you very much.
Thank you, Dr. Paz.
Take care.
Thank you.